Okay, hi everyone. There should be some more people joining us, but I'm gonna get started. Um, Hello, welcome. Thank you so much for being interested in joining me today. Um, we, Hi, Ethan. We, we, I'm expecting a nice collection of psychiatrists, therapists, nurse practitioners, either joining in the next few minutes or watching the recording later, so I'm hoping that we have something interesting for everyone. I am recording it because a lot of people couldn't make this time. So if you do want to ask a question and don't want to be in the recording, feel free to stay off camera or chat. Um, but it's also nice to be able to see faces while talking. Um, Also, if anyone here has already shared a TMS patient with me, feel free to chime in with any observations once I get to the results section, because it's definitely nice to hear from um, someone other than me about TMS and the results. So let's jump in. So we're going to talk about TMS. Let's just start with what it literally is and looks like in case high likelihood you haven't actually seen it. There's a few different ways it can look. This is what I have in the middle, the MagVenture machine. There's a few different manufacturers of TMS machines. The technology itself is all contained in this little what we call a coil right here. The MagVenture machine and the NeuroStar, it looks like this. There's about 8 different manufacturers. The only one that you're going to see that looks different is the BrainsWay, which people describe kind of like a space helmet. So if your patient tells you that they had a space helmet, they're talking about a BrainsWay. If they tell them that something was put on their forehead, then it's all of the other ones. So they all contain these insulated wires wrapped in different types of configurations. Not going to get too much into the difference between them unless questions come up at the end. Good news is they have all been shown to be equally effective, even though you'll hear the term sometimes deep TMS. That's what BrainsWay calls their TMS. But everyone tries to prove that theirs is the best. No one's been able to, so that's great news for your patient because they just have to find a place that they're comfortable and not really worry too much about which device it's going to be. Okay, so I told you these things are all little packages of insulated wires. So what we're doing here with TMS is passing a large, brief electrical current through insulated wires, very large and very brief. Because of Faraday's law and some other physics, that powerful current creates a magnetic field, and a magnetic field is able to penetrate the scalp and skull. Same concept for how MRIs work. The magnetic field can penetrate all the way through. The magnetic field, once it gets to the superficial parts of the brain, it induces electric currents in those parts of the brain. So we're using physics to induce electrical currents in the patient's own neurons, causing their own neurons to fire, which we do at a very specific frequency and intensity. So we're just getting their neurons to fire over and over again. That's all TMS is. We're not putting anything into their system like we do with all the other drugs. We're just getting the patient's own brain cells to fire, and we're training them to reconnect in certain ways. I'm not going to get too far into the technicalities of how I actually do that in the office, what it looks like, or how we think it's actually making changes to brain circuits. So if you're interested in me getting into more specifics than I am giving, then please ask me that at the end, and I'm happy to go into more detail on any of that. Why do we want to electrically stimulate the brain? This is where it started. In the 1990s, brain imaging was really just coming into being and getting more and more sophisticated, able to see first just the structures, then the actual activity and glucose uptake for, showing us what parts of the brains were active. So we started to be able to see major depressive disorder as a brain disease and what was actually going on in the brain. This was an early PET scan in 93 that Mark George did that really shows us that there is less brain activity in depression. So this same doctor, Mark George, lucky for us, thought to himself, there's this technology in the UK called TMS that can stimulate cortex directly. What if we stimulated underactive brain in depression to make it more active? So he asked that question. He started the experiments. They've continued through the 90s and it worked. That's why we're here. Um, Maybe elephant in the room. If this is so great and it's been around so long, then why are you the only person I've ever heard mention it? Um, it's mainly the cynical answer is really no one makes a profit off of spreading the word about TMS. They do for medications. There's a good incentive for you to have heard of medications and for you to be, prescribing or bringing up medications to your patients. Whereas for this, the TMS manufacturers, advertise to doctors like me to get them to buy the machines. And then once we buy the machines, it really doesn't benefit anyone financially if we use the machines. So I think that's really the main reason that there's not that much, it's just not that much out in the space, because it's up to psychiatrists to self-promote and we're not the best at that maybe. Um, but yeah, it's not new. It's been around. It was invented in 85. Like I said, 90s starts getting developed. 2008 gets FDA approved to treat major depression. And those FDA approvals expand into pain, migraine headaches over the next few years, OCD, by 2020. FDA approval is a big deal. To get a device FDA approved is a very rigorous process. You have to prove that it's safe and it works and that it's superior to what is already out there and that its benefits last. So you can trust the FDA approval for that. And here's the last sort of qualifier, and then we'll get into the meat of things. Briefly, just why do I do this? You may want to know why I'm so into it before you decide if you should send your patients for it. So I'll just kind of tell you how I came to be here. Um, it had to do with this office. I got a new office space because I got kicked out of the old one, and I had a lot of space, as you can see, before I built the walls. And so I wanted to do something else. I had a pretty active psychopharm practice for many years. Love psychopharmacology, love to see all the things that medications can do, but also was starting to appreciate their limitations and just wanted to have something else that I could offer to patients. I wanted it to be something that was profitable, of course, but also accessible and that patients could actually use and not, dip into their life savings to use. So I did a ton of research. I felt like TMS was the best thing that fit into that, because it's covered and it works and it's accessible. And so I ended up, investing a lot into this, into getting these machines and setting up a whole infrastructure to be able to do this because I really believed in it. And then, in the last 7 years, I've really seen it do great things. Okay, so into the actual substance of TMS. What is it? How does it or what's the process for the patient? So a standard TMS course for the most part is 36 sessions. When we get it covered by insurance, it tends to be 36 sessions that they cover, and it's just everyone has kind of it's kind of consensus that that's a good full course of TMS. So 36 sessions. That is can be done 3 to 6 times a week on average, so it can take about 8 weeks. We now have, for the last couple of years, most of the insurances are covering 2 per day. So I ask people to try to come in a minimum of 3 times, and then with the 2 a day and open most Saturdays, they could come in a maximum of 12 times a week. So get through the whole thing and again, anywhere from 3 to 8 weeks. But sometimes that's the first barrier for people. How am I going to do this 36 times? And it really, the regularity and density of treatments is much less important than just getting in for the 36, even if that's a few times a week. Each session can be as short as 3 minutes, as long as 30, depending on what protocols we decide are best for your patient. They're awake during it, usually watch TV, alert, no one has to bring them. They can leave. Most of my patients come before or after work and go straight to work and have no issues. Um, I do also offer a 1 week program, and I think it's worth mentioning this because this is something that you may be more likely to hear specifically from your patients. It seems to have gotten a lot more coverage and reach than standard TMS. For example, here it is on CBS Sunday Morning. It's called Saint, and Saint was just a study out of Stanford in 2020 where they did 10 treatments a day for 5 days and they had really great results, partly because they accelerated it, Partly they used MRI guidance to choose their treatment site. Further studies have kind of that's not what I use, obviously, and the method that I use is very reliable. So there's still kind of the jury's out on which of the aspects of Saint gave it a slightly higher response rate than standard TMS. Point is, you can do as many TMS sessions as you want, as the patient wants and has time for in a day. So I do offer this program where someone can basically like rent out or like just pay for a private room for the week. It's a nice room with kind of an office setup and a neutral background if they want to just conduct work or sleep on the futon we fold out and set up. And it's kind of their room for the day, and they can do 10 sessions a day for the whole week. Um, so far, it doesn't feel to me like it is more effective to do it that way. It's definitely very expensive because we can only get insurance to cover the two a day. So, and I charge a lot because it's a, big resource cost for me. So this could be up to like 25K for a patient. I really don't intend that for anyone who it's only for someone who that is not a big deal. And that's worth it to just continue their business and work through it. I don't really want anyone, it's not worth someone to kind of like dip into their life savings to put all this money into it um, when their insurance would cover it. So we can, if that comes up with your patients, I'm happy to talk about it more, but that's just my side note on Saint. So who are we sending for TMS? Really, anyone with depression is the answer. Severe depression, mild depression, it works just as well. Someone with mild depression is just going to feel even better than someone with very, very severe who's going to, get halfway maybe out of the hole that they're in, or OCD. Um, Again, does not have to be severe. It works for depression. So hopefully someday we'll be thinking of it in the same vein as we do medications. Right now, we have to try medications first if we want the insurance to cover it, but that has gotten less stringent. The insurance is mostly just required two antidepressant trials. Really, the only limitations, psychotic depression, may not work as well. Probably ECT is much better for that. Um, but that's about it diagnosis wise, as long as it's pretty much standard depression. They don't need to stop medications. I encourage them not to. It's better to keep everything consistent through the treatment course. Of course, if someone is looking at TMS with the goal of not being on medications, if they cause them severe side effects, then I'm happy to talk about that. It seems it's a good idea to just kind of have the support from the medications throughout and to continue in maintenance when TMS is over. But I have treated a lot of people without medications who have also done well. And anyone 15 and up, again, recent development, insurances started covering it starting at age 15, which is really great because we definitely need more options for kids and adolescents. So there's really only one absolute no, which is metal implants 10 centimeters from the very strong magnet. So like um, CNS pumps or shrapnel in the brain. That's about it. Relative contraindication is seizure. There is a seizure risk from TMS, so we don't necessarily want someone who's already prone, but it's not an absolute. I have treated some patients who have a seizure disorder and it's still workable. Bipolar disorder is certainly not a contraindication. In fact, I find it very effective for bipolar depression, and there's really no risk of manic induction, even though people originally worried about that. The data really doesn't show it causing mania like SSRIs sometimes can, but it's not an FDA-approved indication yet. And if there's any bipolar anywhere in the patient's chart, the insurance does not want to cover it. So right now, that's kind of a barrier unless it has, we have some patients who are depressed with kind of a bipolar flare, but there's never really been a documented bipolar disorder in the chart, then that's usually going to be fine. Okay, so let's talk efficacy. I'm going to just start quickly with meds so we have some context. This is a big trial, STAR-D. I don't know, it's a long time ago by now, but just kind of looking at all of the medications and how people were using them in natural practices. And what it found was that first-time medications had about a 27% chance of achieving remission. If that failed and you tried a second med, it went down to 21%, a third med, 16%. And by the time you have three treatment failures, your chance of responding to a fourth medication is down to 7%. So that's why we need another option. On the other hand, here's our TMS results. This is from the Neuronetics clinical trials where they looked at people's responses after the course, 3, 6, 9, and 12 months extended from that. So what they found was a purple bar, 62% of people had a strong response to TMS, and 41% of people had a complete remission after TMS. And then those results continued through 12 months after treatment. I see very similar numbers every time I crunch my data and get more patients and crunch the new year of data. It always seems to fall around this 2/3 mark, how many people I'm also seeing respond and 40% remitting. So it does seem to be kind of a specific characteristics of this treatment. Does mean that a third of people don't respond. Um, as I've kind of already said, yes, it is covered by insurance. It is covered by every single insurance. There were a few holdouts that came on board last year. So any insurance that your patient has should cover TMS. Most of them have a requirement, like I said, two medication trials. It always has to be from two different classes. So two SSRIs isn't good enough, but SSRI, SNRI, Wellbutrin. Some of them require therapy trials as well. A lot of them are dropping that. Um, yeah, and they've been great. I mean, I haven't really had to fight that hard. They've been good about covering it. This is a really big vote of confidence. Obviously, they don't cover things lightly. So the fact that these insurance companies are behind it and think it's worth their money to pay for this treatment for patients is a pretty huge vote of confidence. If you're not sure or you're curious, you can Google any of the insurance companies' TMS policy PDF. And each of them have, like, this is Optum's, this is a 22-page document explaining what their criteria are and why they cover this clinical evidence rationale. So if you or your patient are still nervous, like I think this is pretty reassuring. Okay, so let's talk about what TMS actually does for patients. And I'm going to give it to you in my patient's own words because I think that's most effective. And again, if anyone listening has seen anything of their own patients and wants to chime in, please do so. So this was actually my first TMS patient ever, who was a longtime patient of mine in my psychopharm practice, and she and I decided we should try this out, and she did very well. She said, it's like TMS glued my coping skills to my neural networks. Um, Felt like it enabled her to do the rewiring work with her therapist, and she'd been deeply engaged in therapy for many years and really felt like they did some deeper work. And now she could talk herself from the edge. So when she's, at the edge of the abyss, typically her coping skills all used to just vanish and now they stay and she can like have, much improved self-talk. This was another early patient of mine who was not severe, doing fine on Zoloft, young girl, like very bubbly, seemed fine. She asked me if she could try it, and it was really amazing. Well, she said it was amazing, like magic, like really fast. Middle of the second week, she said she felt over the moon. And I didn't realize she was abusing alcohol, but she told me she stopped because it doesn't feel good anymore, because it doesn't make her more happy, because real life feels good. So that was wonderful. She was a fast, strong responder. Um, some other patients, I've had better thought patterns, more rational thinking, being in a place where I haven't been in years. I'm actually able to achieve a place of quietness with meditation. That's something I hear a lot, just able to quiet the chatter. And then this patient was able to then sleep. I'm in a more relaxed state than even with heavier yoga or meditation. Some patients also say they can kind of go deeper in meditation if they do it during TMS, which is pretty cool. Another patient, she had a fight with her dad and didn't withdraw into herself and lie in bed, which was her usual MO. Instead, she talked to people about it and she was able to cry about it. Um, this was in the middle of treatment. She really felt a perspective shift. She only used to be able to see her dad as all good or all bad, and then she kind of became able to see the gray. this is really cool because this is all things she'd been talking about in therapy for a long time and understood and, intellectualized and was on board with it. But this was the first time she actually felt it and could, apply all of this work she was doing with her therapist in the actual moment. Kind of same lines. I can stay with feelings longer, be curious. The threshold for shutting down feels higher. Regarding social anxiety, one of my patients recently, this is early in the course too, so he's not really responding yet, but he was walking his dog and had this sudden awareness that, like, oh, people are people, they're not danger. Just this sudden thought he had. So that's great. I no longer have to battle. I can just exist and be present. I didn't realize that I was never present. This patient's CPTSD from childhood, she couldn't talk about things. She froze up, kind of just went away. My 20-year freeze went away. I became able to discuss things. This is a big deal and a big theme in PTSD patients who I'm treating mostly for their depression, but PTSD responds extremely well and extremely quickly. The hypervigilance, which maybe is more physical and kind of easier to get to, hypervigilance responds very fast. So it's nice because people get relief pretty early. And then, they're able to, like she says, and like some of these previous quotes kind of imply, they're able to do more in therapy, especially trauma work. They're able to talk about things, sometimes even access things that they couldn't before, and kind of sit with it and tolerate discomfort and things like that. It does, for some really, severe patients, it's a lot of work, right? So they finish the TMS and then the work kind of begins because they're able to actually start processing their trauma. So some of those types of patients may actually even come back and do it again, like kind of get to a better place. Depression's still there. They might do another course. Another patient said, my birthday was earlier this month and it was hugely emotional as I realized I'm feeling more capable and whole than I felt in 20 years. I attempted to ski a few weeks ago. I fell 20 times, but that cruel voice in my head was nowhere to be found. So I got up and kept going and enjoyed the views. I am feeling better, much better a lot of the time. I really do attribute it to the TMS because my thought patterns have changed. I feel more alive and less inclined to believe distorted thoughts about myself. Again, I really like the way this demonstrates it's kind of a very like cognitive treatment. It really changes what people are able to do with their own thoughts, which is remarkable to see. And I've definitely seen therapists kind of notice and appreciate this along the way as well. The bad feeling is not gone, but it's not overwhelming or life limiting. I have more space in my brain. I'm feeling a lot more things. So a lot of, you know, different than what the medications are doing. We really don't see that masking or dulling, which is sometimes all the meds can do. Sometimes they're great and they end the depression, but sometimes they just, dull it down a little bit. Whereas with this, we're actually seeing people return to joy, enjoyment, feeling thing. So hopefully these testimonials give you an idea of how TMS and therapy kind of really move hand in hand. Um, it really works the best when someone is doing both. And sometimes someone does TMS and that's it, the depression ends and they're better. That's great. But other times it's much more complicated than that. And you can kind of see from some of these quotes how um, it might just give some of the raw materials for healing, kind of give more access to those things so that they can actually start to do the actual work more effectively. Um, Basically, the way I think of it is therapy changes brains, but some brains are so resistant to change that we might need to make them a little bit more changeable first, and then we come in with therapy and do the good things. Okay, a few other questions that people had sent in, which are good questions. What are clear indications this is or isn't working, and how does a prescriber or a therapist support the work that's being done? Hopefully, I kind of spoke to that a little bit already with some of what I've experienced. Um, I think in terms of supporting the work at the beginning, I mean, it kind of depends on what's happening with the patient. Some people, it's a lot, like a lot is changing. Even if they're feeling better, that takes some getting used to and getting oriented to. So at the beginning, it could be a little bit more just supportive and observational of the changes that are starting to happen. But over time, once they're kind of stable in it, and especially after it's over and the plasticity period is continuing, just business as usual, and doing that the work in therapy that often, like, you know, pushing the patient harder because they are able to take in more and sit with more and go deeper with their feelings. So yeah, that's my answer to how to complement it. Definitely, therapists are often the first to notice the indications that it's working or not. Just changes in thought process. One therapist told me that her patient was able to orient to her distorted thoughts in a way that, like, she never could before. So it could be small changes in thought process like that. It could be little like boosts of energy. Energy and clarity kind of seem to come first, and then the depression itself can take a while to respond. Sometimes it's not till after 20 treatments that the depressive symptoms themselves start to change. Um, few more logistical issues or questions that people ask. What else can we use this for? So I mentioned everyone covers it for depression. Cigna is the only company that covers it for OCD. They added that many years ago. I thought everyone else was going to follow, and nobody seems to be budging. But they're great about covering it. I heard a rumor that some Blue Cross plans are covering it for OCD, so stay tuned. And if your patient is curious, then we can always call, because there's a billion Blue Cross plans anyway, so they're all different. Um, it is also FDA indicated for the treatment of migraine, smoking cessation, and anxious depression. Um, and there's a lot of, as I kind of illustrated here, there's a lot of different treatment targets. OCD is a different treatment target. Instead of the dorsolateral prefrontal cortex, it's up here on the top of the head, the medial prefrontal cortex. So we can treat on the left at high frequencies and the right low frequencies. So this is actually very modifiable and like personalizable treatment depending on what the patient's symptoms are, what they're coming in for. And I have a very specific algorithm about where we start and how we adjust it, and add different treatment locations along the way, depending on how the patient is responding and what their symptoms are. Um, this third bullet, like, these are this is really useful. Smoking cessation, other addiction, it's all, the data so far is really great. It's just not really covered yet. Same with post-concussion post-concussion headaches and TBI. Really great data. Hard to get it covered. The fortunate thing is a lot of these things, like addiction and depression, for example, actually have the same treatment target. So if we're treating depression anyway, sometimes we can still get some benefits on the addiction side of things. As I said, bipolar is not approved, but uh, it works really well. I don't know what they mean exactly by anxious depression, but I do treat depression and anxiety with TMS concurrently, and the results for anxiety are very good as well. So what's the downside? The only side effect is a risk for seizure, and it's extremely rare. So in the original clinical trials, there were none. Overall, the risk is estimated to be about 1 in 30,000 treatments, or that 0.003%. When seizures have been reported, it is usually in patients who have pre-existing risk factors, or when it's not being done safely, so the parameters are above safety ranges. So that is pretty easy to avoid. I screen for risk factors. I don't exceed recommended safety ranges. And then even when seizures have happened in these rare cases, they tend to be self-limiting, meaning like something gets kind of activated, but then it ends, and there are no long-term complications from that having happened. But like I said, the main thing I do is control for risk factors, which makes it pretty easy to avoid. And then that's it. There's really no other side effects. These are some things people reported in one of the clinical trials. They're all just kind of part of the treatment working. It's not the most comfortable thing. You can get, I shouldn't say no side effects. Some people get headaches. I see it about 20% of patients like had a headache like an hour or two afterwards. It responds to over-the-counter normal painkillers. Um, I've treated a lot of people who have migraines. I've never seen it make the migraines worse. Um, so yeah, these are some side effects that were reported in the clinical trials. Nothing too serious. And I've actually never had anyone, this is interesting, like people never stop. Once they start TMS, I've never had someone stop during the course. Even a handful of patients with really high sensitivity who it was just really uncomfortable for, they still finish the course, and most of them are coming back for boosters and are, continuing wanting to do more. Um, so really not a big deal on any of these. Couple other just FAQs to cover. How is this different from ECT, electroconvulsive therapy, which is also a really, really good treatment and is still considered the gold standard in psychiatry. But ECT involves inducing a seizure in the patient on purpose, while TMS is sub-seizure. So trying to stimulate the brain in the same way at a threshold that does not induce a seizure. The biggest downside to ECT is there are cognitive side effects. They're somewhat avoidable. They've done a lot of improvements and developments over since it was invented, but um, I still do see them sometimes in my patients, and I think it's a big deterrent. No cognitive side effects in TMS, probably cognitive enhancement, if anything. ECT requires anesthesia, TMS doesn't. And this I find is the biggest barrier when I'm trying to send people for ECT. They have to go, it's usually 3 times a week, and someone has to bring them and take them home. It's required, and that can be tough. That's not the biggest. I think the cognitive side effects are probably why most of my patients prefer not to do it. Another comparison, TMS and ketamine. For some reason, a lot of people ask me, or when they come to me, they're kind of deciding should they recommend TMS or ketamine. I don't know how those two ended up in the same bucket. Um, I don't think they should be. Maybe it's because people are kind of done with medicines and they're seeing these two as the last resort. Hopefully, I've convinced you that this shouldn't be seen as a last resort and it should be a really early consideration if the meds are not quite perfect. And when I talk about ketamine here, I'm mainly talking about the way people are using ketamine, like divorced of therapy, just kind of going to a clinic, getting an infusion, and going home, which is really not, I don't, is not the way these psychedelics are intended to be used. They should be enhancing therapy. They don't, there's not really they're not really supposed to be working on their own. On top of that, ketamine, if it works, it's great. It lasts a week. TMS lasts a year. Obviously, that's beneficial. I see ketamine as a quick fix, and that's why a lot of patients prefer it because they're going to feel better fast. TMS, they're not going to feel better fast. It's a big investment. It's a big time commitment, but it's really worth it. It's causing this slow change, slow repair, and that lasts rather than the quick fix. Ketamine is supposed, I think it's advertised as like you do 6 sessions or something like that. Most of the patients I've seen go through it are not able to do that and have to continue it, and it's really not a safe thing to be using extensively over time. Whereas TMS has no side effects, no long-term events. TMS is covered by insurance. Ketamine usually is not. Ketamine IV, what we're seeing people go to these infusion clinics for, is not FDA approved. Ketamine intranasally is, so that's Spravato, which I think has a lot of potential. Really, here I'm talking about the way people are using ketamine IV. Spravato seems to be really good, and I'm starting to look at how we can combine it with TMS and how they can sort of augment each other. There's not a lot of research on that because it's like such separate camps that people are not like combining them as much as they should, but we'll start to see that. Both of these are increasing neuroplasticity. It looks like to some extent medications are doing that too, kind of opening this neuroplastic window to like for the patient to be able to change. Wouldn't you rather, with ketamine, it's like a 48-hour window that the patient's not even necessarily going to be with you during. So wouldn't you rather open that window like over 8 weeks that they're coming to see you each week and working with you and all the time afterwards? Okay. Um, Barriers to entry are very high for this extremely involved treatment that people haven't heard of before and their friends aren't doing it. So I do like to do everything I can to decrease that barrier to entry, especially when, you don't really know what it is. They don't really know what it is. You're trying to describe it to them and convince them that they should come see me. And they have depression, so doing things is really, really hard. So yeah, I want to make it as easy as I can. I make the consultation is complimentary because having to pay a ton of money on top of all of that when you don't even know if you want to do it seems quite prohibitive. So consultation's free. I'll usually just get insurance to pay it if I can, and it's fine if not. So if you're a patient, if there's a glimmer of interest, like let them talk to me, let me explain it to them. Um, no commitment. I'm very low pressure. Like, let's just talk it through and see if it's something that might be interesting. So, lot to that end, a lot of ways to get to me. This is the footer of my website. So if they find me and find my website, and it's easier to read on the website. Um, they can call, email, this text thingy pops up and that makes that like sends a text message to me that I respond as a text. So they can use any modes, they can have me reply to them in any modes. You can, if you really think like they can't do it, I'm happy to help. If you want to reach out to me and I'll reach out to them, like whatever we have to do to just like at least make the first conversation happen. Um, yeah, so on my website, which should be very easy to find, like it's Dr. Amy Mednick, DRAMYMEDNICK.com, but like I've checked a few times. If you just Google like Mednick TMS, it comes up, at least in the top three. So um, hopefully it's not too hard to get there to find it. And then there's a TMS button on the website. If you go there, there's a whole referral page. There's a button right at the top to get to the referral page. On that page, that's for you. So I'm going to link this video. Um, there is a link to the Clinical TMS Society, which has a ton of educational resources for patients or families. There's a quick brochure that you can, like the one I emailed out, that you can get. There's a lot of FAQs of kind of like things I've covered and the kind of things people ask about TMS all the time. And then there's also a referral form, again, so you can contact me and tell me how you want me to contact them and all of that. Also on this page, I put at the bottom, I thought this would be helpful, just like um, there's a blurb there that you can copy just with all of the information about just quick blurb, like what this is, if you're trying to communicate that to someone else. Oh, that's it. Um, so hopefully there's some questions or comments. Yes, Ethan, please.
Thank you for doing this, taking time to
Okay.
present this. It's very
Yeah, my
interesting.
pleasure.
I wish I had seen it years ago. Um, what do you find when the depression is entrenched in a personality disorder? Do you find that it's less amenable to this kind of intervention or not?
Um, no, if there is something, if there are two things, right? If there are actual depressive symptoms, they should also respond. And most of the data and the studies on personality disorder show that TMS still works. It doesn't keep it from working. So it shouldn't block it from doing any of these things I'm saying. It should still alleviate the depressive symptoms and it should still facilitate the therapy a bit. So yeah, it's definitely not a barrier
And I
as
know
long
you
as they can
mentioned
engage and trust me and all of that.
I
Hmm.
I know you mentioned the one vignette of the person that was drinking. In general, if somebody's abusing drugs or alcohol, is it contraindicated? Do you want to deal with that first before doing this, or can you start it?
Pretty much, it should be dealt with first. If it's severe, I have patients are still using alcohol socially. That's fine. I ask them, not to come in drunk or like hungover, right? It's just because it's going to affect their physiology. So we want them to kind of be in a good state. So they don't have to stop drinking alcohol. Marijuana also doesn't really seem to have much of a impact, or a blocking effect or anything. So I also don't make people change marijuana habits, like to keep things consistent because we don't want to change sort of the physiology along the way. So they just share with me if they're using a lot or if they stopped. But everything else, I would be worried about, the safety, the seizure risks, the like what's primary and all of that. So, and I've treated plenty of people with addiction problems, and we just kind of make a contract like, let's, try to stop. Let's try to do this instead. It's going to help. And, like kind of trust this process, see if we can kind of get through this before, then reconsider, what you're going to do with your substance treatment. So it's been very effective. I've had people and, they work with their substance team at the same time. And, I'm thinking of someone recently with a cocaine problem who, is very hard for him to stop, but at the same time, like he put so much into this, into TMS, right? It's so much work to get for a lot of people, like to get there. And there, he was like, it was such a big deal for him. He was very proud of himself that he got there. And as people really connect with my staff, and it becomes like kind of a little bit of a mini, milieu therapy, like just being there. So he was sort of he was so committed to TMS that I think he would have been afraid to like mess it up or disappoint us, during at least while he was doing it. And then it started to work. And then, you treat the depression. Hopefully, you're kind of decreasing the impetus to use in the first place. So it's worked out okay. And because it's helps, because it is has good data for addiction, you know, I want people to be able to access it, right, without without perfection. So if they can kind of commit to a period of sobriety, then and they have a good support and go to the meetings and everything, then I'm open to
Thanks.
treating. Thanks.
Thank
Hi, Jennifer.
Hi. Yeah, so I've had a few patients come to you and they've all
Mhm.
had really good experiences. But I think you might have also had a change in which insurances your practice takes, right? Like, so which insurances are you in network with?
Yeah.
Then you're saying they all take it for depression. So how does it work with the out of network versus in network?
Yeah. Good question. So I take Cigna, Aetna, and then Optum is like UHC, Oscar. Um, Actually, recently or at least this year, the New York City employee PPO is also, it's like a lot of the New York City employees are now able to see me.
Oh,
So all of those sub plans of Optum, UMR, there's like so many of them.
so you're in network with Optum, Cigna, and Aetna?
Yes.
Oh, wow. I didn't
Yes.
realize that.
Yeah.
And you
Um,
the OCD protocol.
for Cigna, I can bill for OCD.
Right.
The others, like I might not be able to, or might if we're treating both, sometimes that's
Okay.
um and then there's Carillon, like which used to be Beacon.
Uh-huh.
I I've applied to be in their network, so they will usually cover it because I'm waiting for it's in process, so they'll usually do a single case agreement because of that. I happen to have applied like 5 years ago.
Okay.
So I don't know if I could call that a network or not, but I always get it's always worked out. Like I've always gotten those patients covered. And then that really just leaves, well, so Medicare and Medicaid, they're really good about covering it. They're not willing to do like a network exception with me.
Oh,
So there's really no way around that. If somebody wants to use Medicare, Medicaid, they should go. They can't see me unless they want to pay out of pocket, but why do that if it's covered?
right,
And then so for Blue Cross Blue Shield, I usually can get a single case agreement or network exception where they'll agree to just like do a single contract with me.
right,
Usually they may be doing less of that. And then when it's when people have good out of network benefits, that works out fine. And I'm still like doing all it's complicated, so I'm doing all the billing for that. And then they
right.
might be getting paid back. So for those Blue Cross plans, that's been working out fine also.
Okay. Yeah, no, that's really good to know. And so like for Medicare, for example, they don't do out of network, right? So somebody who has Medicare, they would have to just
Exactly.
pay out of pocket.
Exactly. Yeah. I tried a few times, but they're like, absolutely not.
And then last question, I have someone who I think could benefit, but she's older. It's not her, that she's so old. She's only 68, but she's also, like really not in physically good health, and it's hard for her to come in. So you were saying as long as the 36, like it doesn't have to be a certain number per week. So like if it's hard for someone to come in more than twice in a week, how would that look?
That would be okay. I mean, it would work better than nothing. I've been told that, I mean, this is not like a validated in a study, but 3 per week seems to be a good minimum to know that you're kind of like building momentum. But even we also know that up to 2 weeks between treatments is fine, doesn't affect final outcome. So technically, like that means you really could do it once every 2 weeks and
Uh,
still build a benefit. So I aim for 3 a week, but some people can't do it. And to come in, once or twice a week, especially because most insurances cover two a day. So
right.
technically she could like come in twice and do 2 sessions and then we're already at four. And that's good.
Right. Do you see
Um,
it helping with chronic pain at all, like in patients with depression and co-occurring chronic pain?
Hit or miss. There's great evidence for it and pain, but like everything with pain, it's like some stuff works perfectly for some people. Like it seems to be very dependent on like pathophysiology of the pain.
Right.
So it's like has really great evidence for use. It was actually, I didn't mention this. It was an additional indication was approved recently for pain, which is actually using it's not exactly TMS because it's peripheral. So we can actually take the coil and just like slap it right on the joint that hurts.
Oh, really?
So
Oh,
then it's not brain stimulation anymore. It's really like direct nerve stimulation. Um, that was a new approval. I've done some of that. Like my TMS sales guy like told me he has sciatica. He just like slaps it on a sciatica and like it's great. Definitely
wow.
like neuropathic pain and just specific types of pain that helps. And it's really doing an inhibitory thing on the
Right.
peripheral nerve. There's other protocols where I guess one of the main validated things for pain is to actually treat over the motor cortex. So you're
Mhm.
stimulating directly over the motor cortex, which has some benefit. I don't know, like kind of rewires things or kind of corrects some of the aberrant signals that are happening with chronic pain. So it's really good. It's just, it's not covered. Usually, if someone is coming in to see me for depression, I'm happy to like kind of add something on. And so some people
Right.
will do their depression treatment and then sit on my coil for a minute and then go about their business. Um,
So
so the
funny.
answer is
Yeah.
yes. It's just a little
Yeah,
complicated.
no, because this person definitely has depression, but also has like co-occurring cancer pain and then other types of pain. So, yeah, great to
Yeah,
know.
and then sometimes like treating the depression or even just, the PFC stimulation and treating that. Sometimes because of like all the like the fact that it's kind of regulating all of these other networks and they kind of get a little bit more regular, it can kind of help a lot. So I could see the depression, sometimes the depression treatment helps the pain syndrome also, just like it's standard. So yeah, it'd probably be
Thank
helpful.
you. That's
Yeah,
so
sure.
helpful. Thank
Thank
you.
you for the question. And like for some people who are considering this and for their therapist, patient and therapist, like and treatment psychiatrist NP, it sounds impossible. Like someone who is like severely depressed and has trouble getting out of the house, we're asking them to get out of the house 36 times. Um, I've seen a lot of patients that didn't think they could, and it just somehow like it keeps working out. I think there's a little bit of like I think there's a little bit of a reinforcing effect early on. I think that's kind of back when I said nobody quits because of the pain. I think there's something about it that like right away kind of is self-reinforcing and people just want to continue it even if they're not subjectively feeling anything yet. So I can think of a number of patients that were like, I'll never be able to get out of my house regularly. And then they do. And then obviously that's good. Like right then they're like now they're getting out of the house. Now they have somewhere to go to. And so there's, benefits built into that as well. But it's been less of a barrier than you would think. Any other questions? These are great questions. Thank you. Yes, please.
Quick one. Does insurance generally cover the boosters after the 36 rounds?
That's a good question. Um, the short answer is no. We're not allowed, like, there's no such thing as maintenance TMS. They're like very insistent that like no, there's no maintenance TMS. That's not true because I do it and people maintain and it works really well. So boosters are great when someone has a really full benefit and then let's say a couple months later they're still feeling great, but they're just feeling it wear off a little bit. One treatment like resets them to where we finished at 36. It's so effective. So I have people that do come for the booster and it doesn't take much, one treatment and maybe every few months. So there are ways to get it covered. Some of the insurances will cover a new course after as little as 2 months. So we can it's a booster, but we're getting a new course, so we can get it covered that way. Some of them are 6 months or a year. Um, but and then some people pay out of pocket, and I can be flexible with that because I don't want the cost to be a barrier when it is going to keep them from needing a whole new course. So we've been able to make the boosters happen one way or another especially because so little is needed. I don't mind someone just, coming in for one. So that works out pretty well. And then once someone has a response, and we document it, that's like an overarching criteria for all the insurances. If you've responded to TMS before, they cover it again. Like no, like I'll go to an MD review because they don't want to cover it because this or that med, and then they've said to me, "Oh wait, they did it before. Oh, okay, never mind, you're good." So like kind of free pass. Once it works, you're gonna get it paid for again, which is really nice. Any last questions or thoughts? Well, thank you so much for your interest and your attention and joining me today and your great questions and your work with me in collaboration. It was very much appreciated. And hopefully we'll talk about a patient soon. I'm always happy to, even if you're not sure, like if there's a case that you're thinking about, like happy to talk it through.
Yeah. Thank you.
Thank you. See you. Bye, guys.
See you.